More natural.
Yes, yes. I'm gonna let Ginny do a little intro for you, just so whoever watches this has a little bit more information on you. And then I just have a few questions, as to the interview you just did with Ginny. So take it away, Ginny.
Okay, well, Dr. Libman, who I've known since 2009, actually, he's been my neurologist. He is the vice chair of neurology at LIJ, uh, co-director of the Stroke Center, professor of neurology, the Zucker School of Medicine at Hofstra Northwell. Several lines in your signature, and it's all very, very impressive. So, and we're always impressed.
Yeah, I mean, I can't believe, like I said, how much. So I know that you were just talking about something that Dr. Lippman, you should have asked him. So can you follow up with that, Ginny, on the conversation you were just having with him, a question you had for him?
Okay, yes, he was talking about the mechanical retrieval of large blood clots in the brain. And my question was, if the TPA, the clot buster tenecteplase, has already been administered, does that create a problem with them then going in with the catheter and pulling out that large clot?
And that's a great question, Ginny. And it is absolutely no problem to treat with both clot busting drugs like IVTPA or tenecteplase, followed by mechanical clot retrieval, pulling out the clot, as we were discussing before. In fact, right from the very beginning, all of the studies of mechanical clot retrieval were done, which included patients who also received treatment with clot busting drugs. Now, of course, there will be many patients who don't come in within that 4.5 hour window. Remember, that's the standard now, 4.5 hour window for clot busting drugs. They come in later, and we have definite proof that mechanical clot retrieval is effective up to at least 24 hours. So patients coming in within under 4.5 hours get treated with clot busting drugs, followed by mechanical clot retrieval. Patients coming in between 4.5 and 24 hours go straight to mechanical clot retrieval. And just by the way, as another side note, as I introduce slight little tidbits of additional information to you along the way, we didn't discuss it at any length, and maybe we will the next time. There is some growing evidence that for clot busting drugs like TPA or now tenecteplase, used a little more commonly in many places, that 4.5 hour window may not.
Sorry, I forgot to turn that on, but go ahead. We're
Oh, good.
videotaping it anyway.
Good.
Yep, yep.
That 4.5 hour window for clot busting drugs may actually also be stretched out to 24 hours, believe it or not. And
Wow.
there are now several studies, some looking at TPA, some looking at tenecteplase, using the special CAT scan imaging that we have now, looking at how much brain has been damaged, how much brain is not getting enough blood supply, but it's still alive and can be saved. There are studies that are suggesting that we can give even IV TPA, the clot busting drug, or tenecteplase, up to 24 hours safely and still you have beneficial results. Now, before you ask, because you might, that is not standard of care, not FDA approved. It's out there in the literature and it's been published. But there's a big transition point between that and actually making it standard of care. The studies were actually done in other countries, mostly in Asia, not in North America. So if it works in Asia, will it work? It should, but you can't automatically extrapolate different health systems, different other types of treatments other than the stroke treatments. You can't automatically extrapolate. So I'm just sort of putting it out there as a little bit of exciting news just to whet everyone's appetite. And maybe the next time we'll have even more information on stretching that time window for IV clot busting drugs out to 24 hours, just as we have that 24-hour window now for clot retrieval. Wouldn't it be great if we could even offer clot busting drugs as well? Don't forget, there are some places in the world, and even some places in the United States, in rural areas where you're living too far from a major stroke center. You maybe by helicopter you can get there in a reasonable.
Yes.
You can't get, but if you could stretch that window for the clot busting drug, because they may not be able to get to the comprehensive specialized stroke center to get mechanical clot retrieval. Imagine if you could be treated at least with the clot busting drug at 12 hours out, at 15 hours out after the onset of the stroke.
Mm.
So that those data look very, very promising, but it's a work in progress.
I think you had mentioned that to us before, if I'm not mistaken. I
I
think
had
you,
mentioned,
I think so, because I remember someone saying that the window has expanded. But
yeah.
it's all in discussion. So
Renee, what we knew before and what I probably mentioned was there is some information that you can treat even out to 9 hours
yes,
using special, and that's 9 hours. But now there are studies suggesting even up to 24 hours.
wow, that's
So
incredible.
when you
Yeah.
think about it, the additional percentage of patients who are coming in later that you can treat, I mean, it's just tremendous. So we're not there yet, but I think we will be soon.
I think it would be awesome if there was some sort of ambulance that could be like a paramedic, that when they go to these people that live so far away from the hospitals, that they can treat them right there in that ambulance rather than have to wait until they go all the way back. Because time is of the essence for stroke patients.
Well, 100%, Renee. And I can't remember whether we ever mentioned this before, but there are so-called mobile stroke units, which
Yes.
are
Okay.
ambulances which are equipped with CAT scans.
Okay.
And
Stony Brook, doesn't Stony Brook have some kind of stroke
they,
vehicle?
yes, they do. And again, it's called mobile stroke unit, but it's basically an ambulance with a CAT scan,
Okay.
larger than the usual ambulance. And the studies that have been done so far have been fairly convincing that you can now treat patients in the ambulance with clot-busting drugs,
Good.
and that the outcomes are better. Um, it's remained, not so widespread because the investment in that kind of technology is huge, and it's a huge amount of money. And whether all healthcare, the sort of cost and benefit and this and that, but nonetheless, the concept is out there, and it is being used in a few centers in the United States, in a few centers in Europe, so-called mobile stroke units,
Yeah.
where patients are getting treated in that golden hour within
Yeah.
the first hour of onset of their stroke, which is possible but harder when you have to bring them to an emergency department.
Yes. Yes.
So
Sure.
it's not widespread yet, but your idea is exactly on target.
Yeah.
And will everybody start doing this? Will every major health system start? Probably has to be a little more information on cost effectiveness and this and that, and a few more studies, but it is looking extremely promising.
I mean, let's at least do it for the locations that live far from
Yeah.
hospitals. Like we all have hospitals within, a short and close enough. We're not talking about we're talking about out west or something where they live far away. So
Any rural areas,
yeah,
even in New York State and other
yeah,
areas,
yeah.
there are huge distances, and that's why there's helicopters and things like that, but that doesn't solve all the problem.
Yeah, I agree. I agree. So we were on talking about the TPAs before, and I have a question for you. We just had Nicole on the show this past Sunday, an incredible inspiration. She was 21 or 22, I'm not sure. She suffered a major stroke, and she also had an aneurysm after she had a major stroke. And they gave her TPA, and she was allergic to it. So I'm just curious, is that very common that people are allergic to the medicine, and what's the treatment for it?
Yeah, okay, that's a great question, Renee. And allergies to TPA or tenecteplase do exist. Did she mention by any chance what was her allergic reaction? Did she swell
She
up?
may have, but I don't remember. Well, I'll have to go back to the show and look at it. But I was just, I was like, that's something that stuck with me. Wow, you were allergic to it. So that's another for topic for discussion.
Well, let me tell you, allergies to TPA and allergies to tenecteplase, TPA was described right from the beginning, so everybody knew it could happen. It's a small percentage, probably about 2%. In some studies, it's up to 5%, which seems like a lot, but it's probably on average about 2%. And the most common allergic reaction is what's called angioedema.
Hmm.
Angio relating to blood vessels because they dilate and lose fluids and things like that. And edema, edema swelling, basically fluid
Right.
and swelling, angioedema, and the most common reaction, allergic reaction to TPA or to nectar so-called angioedema, tends to affect the lips and the tongue, so that you will see someone after within minutes sometimes of getting TPA, the lips and the tongue swell up. Usually it's manageable by giving things like Benadryl and one dose or maybe two doses of steroid like prednisone or something like that.
Right.
Those are
Right.
anti-inflammatories, they just bring down swelling. Usually it's manageable by that. Sometimes it can be so severe that the person can't talk anymore because their tongue is so swollen. So it's not even part of the stroke, but rather because of actual physical swelling of the
Right.
tongue. And sometimes it can be so bad that it can start to block your airway. And then people need to have a tube, intubation tube down their throat and
Wow.
be put on a ventilator temporarily. That's very rare, but very rare. The most common is just swelling, and you can give Benadryl, that type of medication, and or some steroids like prednisone or something like that, and that does a very good job in taking it down. A small percentage have it. If you have it, it doesn't negate the benefits of TPA, by the way. Whatever it's doing for your stroke and breaking down blood clots and restoring the circulation to the brain still exists. It does not detract from the benefits of TPA. Here's the incredibly interesting observation
Wait,
about,
before you
yeah,
continue, I just want to reiterate what you just said. So you just said that even though they're allergic to it,
yes,
it does not affect or negate
yes.
the how it should work, and it does work on the person,
That
right?
is exactly right. It's still doing its job. The
Okay.
fact that you're having an allergic reaction is unfortunate,
Okay.
and we are responsible for dealing with that. But
Okay.
it does not interact or overlap with the clot busting benefits of the drug. So it's
Okay.
completely separate type of reaction. And so here's the fascinating thing about angioedema, swelling of the lips and the tongue in stroke patients. So to back up a little bit, anybody can get angioedema. Anybody.
Mm.
You can get it as a reaction to a medication. You can get it to anything. It's an allergic reaction. And when that happens, your lips swell up and your whole tongue swells up. All your lips and all your whole tongue swell up. So um, there is a type of blood pressure medication um, to which this type of allergic reaction is actually more common than with other types of medications. So if you've heard of medications like lisinopril, I'm trying to think of other names. They're in a class of blood pressure medications called ACE inhibitors, lisinopril, and there are others. They usually end in IL, and they're quite commonly used as blood pressure medications. They're very good blood pressure medications, and they're very safe and they're very effective, but they do have a slight propensity to cause the allergic reaction called angioedema. So some
Oh,
people taking those types of blood pressure medications, they take their medicine and their lips and their tongue swells up. Now, TPA can cause angioedema.
hmm.
If the stroke patient happens to be taking one of these blood pressure medications, then the chances of developing angioedema are slightly higher than
Hmm.
if you were just getting the TPA and you were not on one of those blood pressure medications. So now that's a little bit of a double whammy, but it's still not usually a major problem. And usually it's very treatable. Lips and tongue swell up. Here's the fascinating thing. If you are a stroke patient and you get TPA, with or without the presence of one of those blood pressure meds. You can get it without. You can get it because, in addition, because you've been taking that blood pressure medication. So with or without, and you develop angioedema, swelling of the lips and the tongue, and you've had a stroke, and let's say your right side is weak or paralyzed, the swelling which occurs is only on the right side of your lips and the right side of your tongue,
Wow.
which when you think about it is amazing
It is
because there's
amazing.
really no reason that I can think of that would, once you have an allergic reaction and you happen to have a stroke affecting your right side, why would the allergic reaction only be on one side of your lips and your tongue? I mean, it's almost unheard of in any
Yeah,
other context. Whoever
yeah,
heard you have an allergy, you know it's all over. You get a
yeah,
rash.
yeah,
You get a
yeah,
rash from an antibiotic or medication, it's all over. It's never just on one side of your body. So that's the fascinating thing. There's something about the effect of on the brain of the stroke that modifies the allergic reaction so that now only half your tongue and half your lips, same side as the paralysis, same side as the weakness, they swell up. That's the deal with allergic reactions to TPA or tenecteplase. It's pretty much the same thing. It's a small percentage. It's usually manageable. Very, very rarely do you need to get, onto a ventilator because it's blocking your airways and things like that. Very, very, I've seen that a handful of times in 30 years. So, but it does occur, and you have to treat it when you see it.
Right. And what I'm assuming is that that they're going to move forward and give you the TPA because the stroke overrides the allergic reaction, even if they know you're on blood pressure medicine, right? They're
That
going
is
to,
correct. That is correct. And usually the decision is now taken out of our hands with tenecteplase. One of the reasons tenecteplase is so quickly replacing TPA is that TPA has to go in as an infusion IV over an hour, which causes some complications, really. And more IV fluids, machines, pumps to get the fluid in, all kinds of things. Tenecteplase is given as a 5-second injection. 5 seconds. Boom. It's in. That's it. If the patient develops angioedema, I mean, for better or for worse, there's no drug to stop at that point. And
right.
again, usually it's manageable. The tenecteplase benefits in terms of the stroke are almost still going to outweigh the risks in terms of some swelling around the lips and the mouth. Not to trivialize it, um, but it does not have the same effect as the stroke will on the patient. So we treat the patient for stroke.
That's incredible. That's just, the information, it just blows me away, how the body works and how the mind works and just, we're miracles.
Really?
We're miracles
Yeah.
and so many miracles happen. And just the fact, like you're saying, that, if you have a stroke, the allergy only works on one side. That's incredible. That's something to like research and
It's
study.
amazing.
It's
No, I'm sure
amazing.
there are all kinds of theories as to why it happens, and you could call it a hemiallergy instead of a hemiparesis, half the body weak, hemiallergy. And there are all kinds of, complicated biochemical theories about why it happens, uh,
Yeah.
which I cannot repeat, but it's an observation, that's for sure.
Yeah.
Okay.
I have kind of an off-topic question. I know we're going to have the time change again this weekend, and I hear reports that the incidence of heart attacks go up right after a time change, forward or backward, I'm not sure. But is there a time of year or a time of day when either brain bleeds or ischemic strokes are more common?
Yeah, I was going to ask that. I just want to add to your question, Ginny. Like Ginny said, the time changes this weekend and we're going into the holidays as well. And the holidays, as beautiful as they are, they're stressful. So, yeah, so tap into Ginny's question.
Okay, so those are two great points and two great questions. Is there a kind of a circadian rhythm, some kind of time rhythm to the onset of stroke? And are there certain triggers for stroke as well, which I think was kind of the second question. Is certain types of life events and others, can it trigger a stroke? And so that's the fascinating thing. In terms of the timing of stroke and the timing of the onset of stroke, that's been published for a studied for a long, long time. One thing that is known is that cold weather, meaning winter, is peak time for intracerebral hemorrhage, meaning bleeding types of strokes. Wintertime, cold weather, bleeding in the brain goes up. It does not have a major effect on ischemic stroke or blockage types of strokes. However, there are peak times for stroke during the week and during the day. And most ischemic strokes due to blockage occur in the early morning or in the time frame between 6 a.m. and noon. The second most common is between midnight and 6 a.m., And that's one of the problem childs of stroke, as you know, because then people are not aware they have their stroke. They wake up with their stroke. We can't quite figure out when it started, and we have to use all kinds of methods to decide if we can treat the patient or not with clot busting drugs. But that's the second most common, in the middle of the night, basically. And then the interesting thing is that Monday mornings, compared to all other days of the week, are the most common time for strokes to occur. And so the morning effect may have something pretty physiological to implicate, because it turns out platelets are different in the morning, the little things in your blood that congregate together to block off blood vessels. Platelets behave differently in the morning. Blood pressure is different in the morning. And Monday morning in particular, of course, as many will know, is a stressful time. Now, I understand some people are unemployed and maybe retired and this and that. So maybe Monday morning has no specific difference compared to any other day. But for a large proportion of the population, still employed, and remember, stroke does affect a lot of employed age people. It's not just an old person's disorder. There's something about Monday morning and stress, most likely, which may act as a trigger for stroke. It's hard to know whether you should really use the term cause of stroke. That's kind of a controversial area. Should we call it a cause, or do we call it a trigger? But maybe it would have happened anyway, but it sort of makes it a little more likely. And that, as a segue to Renee's question, how about holiday time? Stressful times, supposed to be happy times, and they are, but everybody knows the stresses that are associated with holiday times as well. And it has been pretty conclusively shown that any kind of emotional, psychological stress increases the chances of having a stroke within a limited time frame around that stress. So that it may not be 2 seconds later, but it may be in the next 24 hours or something like that, of a stressful period. And then as the farther out you go in time from that stress, that increased risk of stroke seems to peter out. So there's almost no question emotional stress causes changes in blood pressure, may changes in coagulation of the blood, changes in heart rate, changes in the autonomic nervous system, everything that controls our pulse, sweating, body temperature, blood pressure, all these things change. And so diurnal variation, meaning strokes more common at certain times in the day, mornings, and in that nighttime period between noon and 6 a.m. Monday mornings, seemingly the worst of all other days, and psychological stress being considered a trigger for stroke, to categorize it slightly separately from risk factors for stroke: high blood pressure, diabetes, smoking, cholesterol, physical inactivity, alcohol, obesity, all considered risk factors for stroke, long-standing, and then triggers for stroke that somehow may have a more immediate effect to increase the likelihood of causing a stroke. And right now, there's a big discussion in the stroke community. Well, should we start looking at things like stress? Even recent infections, by the way, recent colds, flu for sure, COVID, everybody knows, as triggers for stroke, triggers, recent infections, psychological stress. Well, should we recategorize them and really call them, this was the cause of the stroke? Nobody's been quite willing to go that far, because cause is a very strong word. Like a blockage in a blood vessel is the cause of the stroke.
Right.
Atrial fibrillation, such a strong cause of stroke. Risk factor, but cause, because it releases a clot that travels up to the brain. Hardening of the arteries, atherosclerosis, a cause of a stroke. Should we consider psychological stress or recent infections as the cause versus a trigger versus something else? Maybe it's just semantics and what word we use, but just so you'll know, that's in the literature now, where people are sort of batting it back and forth and saying, how should we look at these things? But they exist, there's no question. It's just a matter of how we describe them and how we categorize them.
I can't imagine that you could, I mean, you'd have to really have to evaluate the entire picture, right? You'd have to really, I don't think it's something you could just determine immediately. You'd have to really look at all the factors of their life,
100%.
yeah,
Renee, and look, I can't tell you how many patients come to me. I see them in the hospital and they're, in the acute stage of a stroke and it's bad and they're distressed and maybe they're paralyzed or somewhat etc. And how many people have said to me, they sort of imply that they were having some stress in the family or something like that. And they say, usually a disagreement, they're fighting with their spouse,
right,
something's happening, they're arguing. They say, could stress have caused my stroke? And I have to always be very careful the way I answer
yeah,
because there's a lot of guilt involved. And they sort of feel that guilty in a way that they're responsible for bringing on their stroke.
mm,
And that's the last thing I want to say. At the same time, I don't want to lie to them and say that emotional stress is totally unrelated because the studies do suggest that stressful events commonly precede stroke in this narrow time interval that you can't ignore.
right,
So I will usually say something like, look, stress is not good, and stress may have contributed
yeah,
in some way to the stroke, but I can virtually guarantee you that the fact that you haven't taken your medication for your blood pressure or your
yes,
diabetes and you've
yes,
continued to smoke for the last 30
yeah,
years
yeah,
has contributed 1,000 times more.
yeah,
So you'll have to change the things you can concretely change,
yeah,
start adhering and taking your medication, et cetera, to reduce the risk of stroke. And yes, is it healthy and good to reduce stress? We should all be stress-free. Show me
yeah,
the person who has no stress anywhere in the world, I'll eat my hat type of thing. But yes, if you can reduce stress, that will contribute to your quality of life. And will it reduce the chances of having another stroke again? Perhaps. Yes, it's good for you no matter what.
yeah,
Most importantly, take your medicine for your blood pressure, your diabetes, stop smoking, etc.
yeah, yeah.
It's a very tricky area.
I know. Well, you answered it correctly because it only plays a part in it, right? I will tell you that for recovery, I've learned and I've experienced and I've had many discussions with many patients, as you probably have as well, that when you've had a stroke and you're trying to recover from it, the stress and the anxiety prevents you from having full recovery, being able to, and that's one thing in my life that is really my goal, is to understand how to get from having a stroke and your brain being frazzled and defragmented. That's what I call it, like a computer, it's defragmented.
Yeah.
How do you understand that you really need to be calm to be able to recover better? That's like when we've had people on our show that they're having problems with aphasia and they can't talk. And my first comment to them is relax. Like, when it comes to you, it comes to you. Just relax. Don't worry about it. And you have to be in that state all the time. And I will share with you that we had this one couple on that he was such a wonderful support of his wife, and he didn't answer for her, which is hard for partners of people that have had strokes, because you want to support them, you want to do everything for them, but you're not benefiting them. So he just looked at her and said, I love you, but let me know if you need my help. So she knew that he was there for him. That's a whole different show about
Yeah.
support for after strokes. But I stress is a big factor in it. It's a big factor.
100%, Renee. And that opens the whole topic of post-stroke depression, which is probably the most common psychological effect of stroke. And sometimes it's psychological, but sometimes it's an effect of the stroke itself, not just a reaction to the stroke, but the stroke itself. And it's clearly shown that if you treat the depression, of course, the person feels better, doesn't feel so depressed, and feels happier. It also results in better recovery after stroke, better
Yeah.
rehab, better
Yeah.
performance in better participation in rehab, better management of risk factors, taking medications, watching the diet. Everything changes when depression occurs and changes for the better when depression is treated. So it's the same general category. Anxiety, also so common after stroke. And by the way, just talking about aphasia, and not talking, we've occasionally had patients, we all know people in their lives, they tend to be a little less talkative, they're more talkative, this and that. And we had at least once, if not twice, um, the man has the stroke, husband, and he's become now completely mute because of aphasia, cannot generate any speech. And, we're examining him, and we always want to know what the patient is like at baseline, what has changed. For example, some people have had a stroke in the past and they're already a little weak. Well, how much weaker are they now? How much can we attribute to the new stroke versus the old stroke? We need to know that before we make decisions about clot busting drugs. If they've had any kind of disability in the past, how much has the stroke added to it? Because if it's added this much, we may not treat. Whereas if
Right.
it's added this much, we may treat.
Right.
And there was one patient who the husband was basically mute, and the wife was the spokesperson, of course, because we needed the history and all that kind of thing from her. He couldn't talk to us, and I just said, she said, "Well, has he had a stroke?" And I said, "Well, look, we think so. It was very early, and the CAT scan didn't show anything yet. It was too early." I said, "Look, we do think he's had a stroke. We think he has a problem with language called aphasia, where you can't talk, you can't generate." And she said, "Well, we've been married for 40 years, and he's the quiet type." And I said, "Okay, I got it. I understand there are some husbands, who sit around, they like watching football games and they don't communicate much with their wives and this and that." But I said, "But are you telling me that he basically has said nothing to you for the last 40 years?" I had to distinguish between what he was, right now, and just being the quiet type, the quiet type of husband.
Right.
She had to think about it, and she said, "No, he's just pretty quiet." But finally, of course, we did get from her that no, he does hold conversations.
Okay.
So,
I
but
was thinking to myself, maybe she's just overpowering that
Yeah.
he doesn't even bother saying anything because it's not worth it.
he gave up a long time ago.
40 years ago.
Just go into the other room, watch the football game. It's safer.
Well, thank
My,
you so much,
my,
Dr.
oh,
go
no,
ahead.
I have one thing to add to this. Stressed spelled backwards is desserts.
Oh,
Stress
yeah.
spelled backwards is desserts. So if you keep that in mind, desserts fixes everything.
Oh, that's very good. Like chocolate.
And that's a good closer because I like desserts, especially at night. And it's late at night and we kept you for
You too.
long enough, Doctor. Thank you so much for joining.
Thank you again.
Ginny,
Thank you
thank
so
you
much.
again. Thank you for interviewing Dr. Littman for for the 7th or 8th time. I forget how many times we've done this.
My pleasure. Renee.